Welcome to this episode of the Healthcare Bridge, where we explore the vital connections shaping our healthcare landscape. Hosted by Nathan Kaufman, Managing Director of Kaufman Strategic Advisors, the Healthcare Bridge is dedicated to improving healthcare delivery by strengthening the strategic and financial performance of healthcare providers. As part of the Common Bridge family, our focus is on fostering insightful, nonpartisan conversations that drive meaningful change in the healthcare industry. We invite you to join us as we build bridges toward a healthier future. The show is available on Substack, YouTube, and your favorite podcast platforms. Search for the Common Bridge and stay connected.
Welcome to the Healthcare Bridge. This is Nate Kaufman. The Healthcare Bridge is an unscripted, brutally honest discussion with healthcare leaders who have intimate knowledge about how healthcare systems work and how healthcare is delivered in our country. Today, we are excited to have Lou Shapiro, the former CEO of Hospital for Special Surgery. Welcome, Lou.
Thanks, Nate. It's good to be referred to by the person I was, as opposed to who I am. But thank you.
Well, we'll get to the ranch at some point in time in this discussion, but let's start with your origin story. Can you give a little background to your history in healthcare?
Yeah, I wanted to be a doctor until I took organic chemistry at University of Pittsburgh, and it was apparent that that wasn't going to happen. Had no idea what I wanted to do. Like many people, they're exposed to the industry because their parents were sick. So I thought maybe I also had a little bit of a business interest. So I sort of stumbled upon the profession, met a guy through my parents who knew his administrative assistant. He was one of those iconic CEOs back in the day. Irv Goldberg was CEO of Life Care Hospital in Pittsburgh. And I was a sophomore in college, met him. He offered me to hang out that summer doing an internship. Didn't do anything meaningful at that time, but it seemed like it was an industry that was interesting. So I made the commitment then that that's the direction I want to go. Applied to graduate school, got in, and in graduate school, back in those days, you were going to work in the healthcare industry in either one or two segments. You would be in hospitals or you could be in insurance companies. I remember sort of vividly standing in the hallway by the auditorium one day, and people were talking about what they wanted to be when they grew up. I said, well, I would be a hospital CEO by the time I'm 50. Very superficial comment. And that's what I decided I was going to do, and just never look back. You had the good fortune of starting off at the predecessor organization of UPMC, had some great mentors then. And then first job was at Allegheny. I was there before, during, and after the catastrophe of the Aher bankruptcy. So I got to see both what great looks like as well as what really bad looks like. Second job was at McKinsey. I was a client before they invited me to join them. You had the opportunity to really work with people who were orders of magnitude smarter than me. They didn't have any healthcare experience, but on the ground, but they were pretty smart. So really, I think sharpened up my skills at problem solving and strategy. Geisinger was a client. I ended up working there under Glenn Steele for 4 years. That was a great experience. I knew I wasn't going to retire at Geisinger, and I knew I wasn't going to be CEO at Geisinger because I wasn't a physician, and only physicians are leaders there, basically. And then I got a call one day about this job in New York, Hospital for Special Surgery. Didn't really know anything about it. I knew what I did know was a CEO job, and that's what I wanted. And then started the interview process. One thing went to another, and they were foolish enough to offer me a job, and I was fortunate enough to accept it, and spent 17 great years there, and decided back in early 21 that for a variety of reasons that was enough time, and started the process of the leadership transition, which took from beginning to end 2.5 years, A+ leadership transition, and handed things off to my successor, who was made for the job, and I think he's doing pretty well now. And
so then you wrote a book
oh yeah,
called From Seat to Soul.
That was an accident, but 40 years went by like that. And really, you look back on it, it's just a great, fun run. Hopefully, made a few contributions along the way, but it was really great.
So you and I are very similar in that I tried to be a doctor. I got through organic chemistry, but when it came to the MCATs, they sent me a note back that said, your horse has a serious infection. There was I just couldn't. I'm dyslexic. I can't take the tests, and I don't like people very much. So they weeded me out correctly, and that all worked out. But so Hospitals for Special Surgery, that is one of the premier organizations in the country. Can you give a little bit of a background on that and what they do, and the key to their success?
HSS is a academic medical center that focuses on musculoskeletal related conditions, musculoskeletal health, MSK conditions. If you looked at it from a revenue standpoint, you would say it's an orthopedic hospital of gargantuan size, and it's been around for a long time. I don't spend much time talking about it because that's in the rearview mirror, but for purposes of this conversation, I guess it makes sense. It's a place that focuses on talent, recruiting. This is the way I would describe it. Brian may describe it differently, but it's a place that focuses on recruiting the very best and brightest in the field of musculoskeletal health, orthopedic surgery, the related disciplines, and making sure they have all the stuff that they need to do the work that they do in a way that serves patients better than any other place can do it. And you do it in a business model that also makes sense for the organization and the people who are part of it. And you try not to take your eye off that ball. And historically, it hasn't. And the results either are attributed to that or just good luck and good fortune. But it's done pretty well consistently over withstanding the test of time and changes in the external environment.
And one of the things that we see with insurance companies is they start talking about reference-based pricing. Well, if why would you pay for a total knee replacement for $60,000 when you can get it for $30,000? I know HSS and others. It doesn't have to be about HSS, but do you view healthcare as that kind of a commodity, or do you think that where you get your care and who provides that care makes a difference?
I think where you get your care and who provides the care makes a difference. That doesn't always mean you have to pay more, but it definitely makes a difference. And anyone who's making decisions on behalf of others, whether it's an employer or the government or a payer, the people who are making decisions, you can be sure they're deciding where they want to go for their care or their family's care. And that doesn't mean that 60,000 is better than 30,000. It just means that there's variability in quality, and that is an important determinant of outcomes. I always just say we may be more expensive on a unit cost basis, but we're cheaper over the course of an episode. So, why wouldn't you want to spend a little? You do get what you pay for to a certain extent.
Well, the Hospital for Special Surgery is located, I think, in Manhattan. What % of your business came from outside the area because of your reputation?
Well, Manhattan HSS and service area back in the day. Again, remember, 2.5 years rearview mirror. So as you're driving along, things in your rearview mirror get smaller and smaller and smaller, so you can't see them. But HSS and service area is basically a 75-mile radius around the Upper East Side, which was all 5 boroughs: South Jersey, Northern Jersey, Southern Connecticut, Long Island, and Westchester. 20 million people, and countless organizations that delivered the same kind of services that HSS did. So competition was significant. And in all those markets, HSS either had number 1 or 2 market share position. Right. So even counting that they had to leave to come into the city for some of the stuff. I think that don't quote me on this, whoever's listening to this, but I think somewhere around 80% of patients came from the primary service area, and then 1 or 2% globally, and then the rest from all 50. There's someone who came in from all 50 states every year.
So enough about HSS. Here's something that will help me, or at least my family. My son is a young, budding hospital VP of operations. Based on your 40 years, I have 50. Based on your 40 years of experience running hospitals, which is what he's doing, what advice do you have? If you could talk to the young managers and executives in this industry, what advice would you give them, either that you did do or that you should have done?
I would tell them to do a few things. Never think you're smart enough. Always allocate time to learning. That's number 1. Number 2, don't stay in the office. Get out to the floors or the places where care is being delivered and understand what's driving the people who are doing the work of the organization. Number 3, what wins is teamwork, not individual performance. So be a great member of the team. And then 4, make sure whatever you're doing that you are having impact by your contributions at a level where if you left after you did whatever you were doing and you came back, and I always thought about this, and you came back X number of years later, people would remember you fondly, and the results of what you did when you were there would be visible, as opposed to having evaporated. That's what I would tell them. And if you want, I will be happy to tell them. You have to call me. I'd be happy to talk to you.
Yeah, I probably will, as a matter of fact. When we look at healthcare today, well, first of all, how we met was you saw me posting on LinkedIn that I thought government policymakers were a bunch of knuckleheads, and then you reached out and said, I got to talk to this guy who calls government people knuckleheads, which I do still think they are. But I guess the environment in healthcare has gotten very challenging. I mean, we have shortages, we have all kinds of things, and there's a couple different ways to look. I mean, you've been through several cycles of, environmental stress on the delivery of healthcare. Do you think it's any different now? It's the same. I mean, how do you feel about it?
I feel frustrated because the longer that you are at something, the more you see history repeating itself over and over and over and over again. And sometimes the words that are being used are different. And obviously, the state of the environment is different. There's different, whether it's, you're going from, in your office getting, writing a memo, handwritten, having your assistant type it, putting it in an envelope and sending it down the hallway, to a person you could just walk down and see, to email, to the internet, to AI. Those things have changed. But so in technology and biotech, all those things, there's all kinds of changes. But at a certain level, nothing has changed. I remember sitting in my office, which was a former bathroom, with Don Berwick when he was just starting CQI, going from different reimbursement environments. It's just the same. Buying physician practices, consolidation, mergers. It's the same thing over and over and over and over again. And it's not that things haven't improved on the fringes. Obviously, science has evolved that helps people solve problems that maybe created lifelong morbidities or mortality that are fixed. But the system is the same. It's too expensive. It's not accessible, and the quality is both great and not so great at the same time. Unchanged.
And so, I mean, what advice or what thoughts do you have about affordability as an example, given your 40 years of experience? How do we make healthcare more affordable? Because hospitals are getting trashed every day because of the lack of affordability, and they're right. I mean, it is too expensive.
Yeah, but everyone can't be the bad guy, right? I mean, so there's some people, it seems like everyone's the bad guy except them. So that can't be the case. The system is structured to, and that's not only the healthcare system, it's the U.S. economy in general. The system is structured to, in my view, to produce the results that it produces. So let's take hospitals. Hospitals do a million things for the communities they serve. They probably shouldn't do a million. They should probably do 500,000 things. You've talked about that. But how do you really curtail your portfolio when you've grown up to be this thing and you're providing all of these different kinds of services to the community? And then they acquire a hospital, they merge, they grow, they get bigger. Maybe that allows them to spread their overhead on the larger base and to invest in technology. But bigger, I always used to say at HSS, bigger doesn't mean better, right? I used to say bigger doesn't mean better, better means better. And if being better allows you to be bigger, that's fine. But just being bigger doesn't allow you to fix things. It's like you live in a house, your family grows, you change, so you renovate a certain section of the house or you put an addition on. Sometimes it's just better to move and build a new house altogether. So I am not hopeful that the industry is going to accomplish anything other than incremental improvements and, to a certain extent, kicking the can down the road more. Maybe that's okay. That doesn't mean people aren't trying to fix it. Whether those people work for payers or employers or pharma or device or providers. People don't wake up every day and say, how are we just going to take advantage of this broken system? People are trying from where they sit. I just don't know that any of it is going to change. I don't think I have I would never position myself as being an expert on this, but to answer your question, I think that there needs to be demonstration projects. And I use the word demonstration project, not meaning it should be a CMS demonstration project, but that people should come together and figure out, how do we build a new healthcare system from scratch that doesn't have all the intermediaries who are trying to connect the dots and, as a consequence of that, extract value. A healthcare system that everyone has some responsibility in, that focuses on health. Health focuses on, like, we take better care of our possessions than we do of ourselves. So we need help. How do we help people focus on health, and then making sure the care is efficient, and make sure all the incentives are aligned, and rebuild that healthcare system from the ground up. And as it grows, if there's parts of the existing healthcare system that can come along with that, that's great. If they can't come along with that, they're either going to be successful by being left behind, or they're going to fail by being left behind. And that I don't know if that makes sense or not, but that's, I just don't think, like, I'm not allocating my time to fixing the system writ large. I'm allocating my time to where I think things can make a meaningful difference on making things meaningfully better. Well, I'm pretty excited about this thing I'm doing in the primary care space. I think the lowest common denominator is how people take care of themselves and receive care. And I think the primary care physician, including their surrogates, whatever gets added to that, whether that's AI or APPs or whatever it is, I think that's foundational. And I'm not sure that the primary care system isn't broken also. Not enough people going into it. It's not a great job when you have to see 100 patients or however many patients they see a day. This notion of direct primary care is a model that this company that I'm working with has adopted, or has been formed as a result of focusing on that. And they work with self-insured employers, and then they find in a large self-insured employers in a market, and it just allows them to eliminate all the friction in the system, so that the primary care physician and their team, which includes people who focus on drugs, mental health, and nutrition, as being all important determinants of both health and care. And they take care of patients in a way that friction has been eliminated. They also, when they're doing that, they also have a relationship with the health system. So along the lines of what I said, health systems have a role in this. So anyway, I'm spending some of my time with that company. I think that's the kind of example of how not the healthcare industry can evolve. Maybe it's an example of how the healthcare industry can evolve, but all of the legacy baggage that exists, it's hard to fix that other than incrementally. So we're building a healthcare system to have people come along if they can join that and see how that turns out.
Before we dive back into today's enlightening discussion, we have a quick message for all you Healthcare Bridge enthusiasts out there. Did you know that you can find these Healthcare Bridge episodes on Substack as part of the Common Bridge series? You can also find written columns and opinions as well. Subscribe at thecommonbridge.substack.com for a full Common Bridge experience. There you can comment and express your opinion on all the topics we cover on this and the past 7 seasons of our podcasts. If you'd rather support the show without subscribing, you can do so with Zelle at rich@richardhelpy.com or using Venmo at richard-c-bridge. Thanks for listening. Now back to the episode.
Yeah, we're on the same wavelength on that. University of Chicago came up with the concept of behavioral economics, and they said, do you need a nudge or do you need a shove? And what we're seeing in the traditional healthcare, I'd say delivery system, are nudges. We're going to change this payment. We're going to add an ACO. It doesn't really change the mess that we have. But the shoves that I've seen, one of them is in primary care. I just read an article about it where between AI and, as you said, nurse practitioners or PAs and a whole bunch of other things, you're able to expand the reach of a primary care physician who, I think we have a 29,000 shortage of primary care physicians. So you can double their panel by creating this new kind of delivery model that is primarily virtual, actually. So it's kind of an interesting approach. I don't know if that's.
So what I was talking about is a little bit like that, but also a little bit the opposite of that, where you cut their panel in half. So if you're a primary care physician and you have to see 30 or 40 patients in a day, how much time are you going to be able to spend with that patient? How hard was that? How hard was it for that patient to get an appointment with you? So in lieu of that, either that problem doesn't get taken care of, it festers, it gets worse, or they seek some other higher cost level of care. So the model I'm talking about, the primary care physician sees no more than 16 patients a day. You can get in to see them whenever you want, whether it's virtually or physically, and they can spend time with you. Get to know you. I mean, it's a little bit of Back to the Future, right? Where a primary care physician and patient has a relationship. And that's where you can, by bringing other resources in, you can focus on making sure they get what they need, when they need it, how they need it, which is going to be much more cost effective than otherwise. And spend time focusing on what are the things that you can do that will make you healthier, rather than fixing your car when it's broken. How do you advance its life so you don't have to take it into the repair shop?
Right. First of all, I love direct primary care. I also love concierge primary care. My primary care doctor limits his practice, concierge doctor, to 50 families. I can get into them in a minute. I could text them right now. Send them a picture of a blemish. He'll get right back to me. The challenge you have is when you limit your practice to 600 families or 50 families or whatever, what's going to happen with the rest of the people that don't have access to that, right?
Yeah, the model I'm talking about is a model for the masses. This is not for people that can do whatever they want, whenever they want, because they have the resources to do it. This is for the rank and file population. The bigger question is, how do you scale that? Like, it's a big country, right? So getting from where we are to where we need to be, I mean, that's a long journey. I certainly do not have the magic answer for that, but I do know where I think starting makes a difference, and that's at least my focus.
So I think we need shoves. We need different ways of doing things, which is an interesting question about orthopedics. My feeling is that orthopedics is becoming an outpatient service, with the exception of complex spine and some other things. I don't know if you see that any differently than I do.
No, 100%.
All right, so let's move on to From Seat to Soul. I am personally very interested in your perspective about this because I am 72 years old, almost 73, and I'm still doing this nonsense. Maybe, as you said in the book, I'm a day late as opposed to a day early, retiring. Why don't you just summarize your experience for people who haven't read this?
Yeah, so this book was written by accident without any intentions to write it. And here's how I came about. So I do view it that having the opportunity to spend 17 years as the CEO of HSS was a privilege of a lifetime, right? So I was all in. I left everything on the field. I was all in on that for 17 years. And I loved the place. I loved the people. I loved the purpose. And I loved the job the role I had in it. I loved it. Then, so you go on and you don't even think of stopping. I had a catalyst to this, which was post-pandemic, or not post-pandemic, during the pandemic. My wife went back to Pittsburgh because that's where my daughter was, and they hunkered down there while I was, on the front line, so to speak, supporting our caregivers, making sure that they could do what they needed to do in that environment. And then, then my wife I was going back and forth. I was like, I've been at this for a long time. Do I really want to do this as long as I had intended to do it? Which was, by the way, 20 years. So if I would stay 20 years, I would have finished up 4 months ago instead of 2.5 years ago. And, I had a discussion with my board co-chair at the time, and this was March of 21. And we went back and forth on it a little bit, and I decided I was going to do it. And we spent March of 21 through February of 23, when it was announced, working on this transition. And in December of 22, which was 3 months before two months before the announcement, it hit me. It hit me like a ton of bricks. And I was not prepared for how I would feel about it. It was like an emotional trauma. And I was like, oh my God, what did I do? What am I going to do? And I was not the most pleasant human being to be around. And I may have been the least pleasant human being to be around at that time. You can ask my family that. And I was like, I got to figure this out. I went up the street, bought a notebook, went next door, got a coffee shop, started writing things down. And just one thing led to another. And during that process, I explored how I made the decision, how it made me feel, and how was I going to get out of this emotional mess that I was in. So I started journaling about it, and then for no reason, I started posting. Like after the announcement, I wrote something on LinkedIn. It was very interesting how many people were interested in that. Not about me, but about the experience, how I was feeling about it. And then it just sort of came about, and you journal, LinkedIn, pulling some of those things together. Just one thing led to another, and the book came out, and just explored all the things that I thought about and all the things that I felt going through this, and that's it.
Well, I mean, when I read the book. I mean, you were very honest that you had a very dark period, and as I look at my personal career, I'm a adrenaline addict, so I need the dopamine going. I need everything going, and I don't play golf, so I don't shoot things. I mean, this has been my life, so and it sounds like it was yours.
Yeah.
How'd you get through that?
I think every individual is completely different from every individual. So what's good for one is it good for someone else? I mean, I have a friend who had a very successful career in a totally different profession. I said, "What are you going to do?" He said, "I'm going to sit in my back deck." Great, if that's what makes him happy. That's great. As long as you do, what's important is that there's a couple things that are important. Number one is, remember, we don't have unlimited chapters. Okay, so if we make an analogy of life to golf, we're on hole 13 or 14, right? So you don't have all the time in the world left. And my view was, I would always say that family comes first, and that's only true, Nate, in words and in crisis. Other than that, it comes second. So if you think about those things, I just decided that now is the time. And by the way, a good time for the organization. 17 years, forget about the accomplishments and the success of the organization. 17 years is a long time. New blood is a good thing. And it's only a matter of time before things go bad, and where that new blood is needed sooner. Right? So it was an alignment of the sun and the moon and stars. This was the right time. And I just decided that, you know what? This time, and when I say family comes first, but only in words of crisis, you as an individual are always last. Now it's time to flip the script. I wouldn't say I'm an adrenaline junkie, but I have a passion to contribute to the field and a commitment that's not going to go away. And I'm not going to play golf every day. I'd like to play golf once or twice a week, but there's only limited things I could do to fill my time. So in my case, and I developed a framework that in the book, I call it we, me, work. We is family and friends, travel, stuff like that. Me is focus on my health, going to the gym, making sure I'm in shape. I'm trying to get better at golf. I'm trying to learn how to play the guitar. I'd like to read a little bit more. We and me is the priority. Work has to fit into that. And look, I'm on 7 boards, right? And that means there's 7 CEOs, 7 management teams that I'm working with to help them do what they're trying to do. Just like I had people who helped me when I was CEO of HSS do what I should. Now I'm just helping. I'm helping from a different seat. So it's still there. But the key is just remember, if you're a golfer, you're on hole 13 or 14 of golf. You don't have unlimited chapters. So don't put off for tomorrow, because you never know what that's going to be. Do it now and figure out when you've done your job that you went to the organization to do. And if you've done your job that you went to the organization to do, that also means you have people in the organization that can carry on for you. And decide when it's time.
So one of the things, I just have to ask you about this because I read the book. One of the things you did was, when you were in a difficult place, you went to the ranch in Malibu. And you said while you were there, you discovered some things.
Yeah, well, I knew a bunch of people that went to the ranch in Malibu, which is a sort of rigorous wellness retreat in California. It's heavy duty hiking and nutrition based. There's other parts of it, but it's serious stuff. And you're doing physical exertion activity. Also, you're in an environment. It sort of clears your mind. So I knew a lot of people that I worked with that went out there, so I always heard about it. And I just decided that when I was in this dark place, that was December of 22. I left I finished in September of 23. In July of 23, I went, right? And I call that my reboot. It was just sort of, everything. And then I think you never know if something was contributory to the outcome or not unless you did an experiment and didn't do it. But I just think it was very helpful for me. Got in shape, cleared my mind, had an appropriate outlook on life. And then 2 years went by, and I felt like I needed to go back for a recharge. And that's where I would call it a little bit of a discovery. And that is, when you're in your next chapter, I was doing this. I was comparing this chapter now, what I was doing professionally, to the last chapter. You just can't do that. It's apples and oranges. For me, like the 17 years at HSS, it could not have been a better experience. So anything is going to be not as good in comparison. So the aha moment when I was hiking by myself in the mountain is that I'm comparing this chapter to what I want to accomplish in this chapter, not what I accomplished in the last chapter. And that is embedded in the We Me work framework. And the work framework is still working really hard, helping these companies that are led by people that I like and are doing things to help the system well beyond the primary care company. There's 7 of them. And I'm helping them. And if I help them and I derive value from helping them, then it's great. If I'm not helping them or I don't derive value from helping them, then I just need to stop doing that because now I'm in control of my time, not the organization that I'm helping lead.
So we're getting close to time. So we always like to end our podcast talking about any advice for patients. You've been in healthcare 40 years. We have patients that watch this or just civilians, shall we say. Do you have any advice for them in terms of how to navigate the healthcare system or anything?
Number one, take care of yourself, right? If you're on a plane and the oxygen things come down, you put it on yourself before you help anyone else. So take care of yourself so you can take care of others, right? There are things that we all can do to be healthier. Do that. Number one. Number two, quality is not the same everywhere. So make sure that you have a relationship with a primary care physician that you trust and that you have access to. And I mean, that's it. I mean, that person that you trust and you have access to is going to be part of a healthcare ecosystem that has the local hospital. Then you're in good shape. And then you don't have to worry about the hospital. You're going to trust that person. If you don't have that, where do I go? Do I go, obviously if it's urgent, you go to wherever you need to go. If it's chronic or elective, then you have choices. How do you really know? Like, how do I know that this hospital, even me, how do I know that which hospital in Charlotte or Pittsburgh is really better? Like, I think I know, but I don't really know. So it's really hard. So you talk to your friends, like looking on the internet and all of the report cards that are out there. I mean, good luck trying to figure that out. That's still way too complicated for even professionals to really figure out, let alone people that aren't in the industry.
Yeah, that's in line with our belief here is that the key is to find an insider. I mean, the real question is not only the hospital, but how do you know if you need a neurologist and which neurologist you should go to and can you get in? Those are the kinds of issues.
But that's where if you have a primary care physician, which is a longitudinal relationship, right? If you trust that person, they're going to be more informed than your friend who said this is where you should go.
Exactly. I'm sure you, like I, get frequent phone calls or used to get calls.
They're reducing in frequency, but they are far from. And it's always happy to help.
Same here. Anything we didn't cover that you want to mention in this little thing?
I think there's sticking to healthcare as opposed to the world. There's so much noise in the system. For all of your listeners who are in the industry, you don't need to spend a half hour on LinkedIn to see how fragmented and challenged the industry is. It would be great and naive to figure out a way to eliminate the noise, eliminate everyone's instinct for survival, and figure out we don't have a shortage of the smartest people in the world here. How do we fix it? There's too much noise in the system.
Yeah, I agree.
Maybe you and I can work.
Yeah, who knows? But anyhow, well, I appreciate your time, Lou. It's been great to catch up with you. It's been a while. And I think we not only learned about healthcare, but we also learned about what we do as we get to the sunset of our career. Maybe you push me over the edge. We'll see. I don't know.
You can still contribute in your next chapter, Nate. Whatever makes you happy is what you should do.
What's happy? I don't know. That's another story altogether. Well, I think that's a good way to end. This is Nate Kaufman with Lou Shapiro with the Common Bridge podcast. And this is the Healthcare Bridge. Lou, thank you so much.
Thanks.
Thank you for joining us on this episode of the Healthcare Bridge. We hope you gained valuable insights into how strategic and financial analysis can transform healthcare delivery. Remember, building stronger connections in our healthcare system is a collective effort, and we're honored to be part of that journey with you. Be sure to subscribe and stay tuned for more conversations that aim to bridge gaps and create a healthier future for all. You can find all your Healthcare Bridge episodes at The Common Bridge on Substack, YouTube, and your favorite podcast platform.